Welcome to the Do No Harm podcast, where we discuss the battle to keep politics out of medicine, with our hosts, Dr. Marilyn Singleton and Do No Harm's founder, Dr. Stanley Goldfarb. Together, we're talking with people to create a better healthcare system for all, one that's based on medicine, not division.
Most of us have heard the quote, "Those who cannot remember the past are condemned to repeat it." Dr. Sheldon Rubenfeld is making sure that never happens. When he's not training the next generation of doctors at the Baylor College of Medicine, he serves as the executive director of a nonprofit dedicated to studying medical ethics called the Center for Medicine After the Holocaust. And it challenges doctors and nurses and scientists to personally confront the medical ethics of the Holocaust and to never forget the horrors of the past so they will never repeat it in the future. For nearly 50 years, Dr. Rubenfeld made ethics a central focus of his work at Baylor. But 2 months after Hamas attacked Israel, the school canceled his lecture on antisemitism in medicine. For the past 20 years, he offered a 9-lecture elective called Healing by Killing, Medicine During the Third Reich. But Baylor canceled the future courses when a student filed an anonymous grievance and, quote, felt uncomfortable, close quote, because Dr. Rubenfeld used the word Palestinian in a lecture about anti-Semitism and countertransference. Then just 2 months after Hamas attacked Israel, the school canceled his lecture on anti-Semitism in medicine. Now Dr. Rubenfeld is bravely confronting what most of his colleagues refuse to admit, that diversity, equity, and inclusion, better known to all of us as DEI, those policies breed anti-Semitism in medicine. Dr. Rubenfeld, thank you for doing so and welcome to the show.
Thank you very much. I'm delighted to be here.
Well, I'd just like to let Dr. Stan Goldfarb kind of take over from here for a moment or two.
Thank you very much, Marilyn. And Dr. Rubenfeld, welcome. We're really delighted that you're here. And obviously this tale of what happened at Baylor and what's been the fate of your course is really the object of the whole discussion today. But first, I'd like to ask you to sort of give us some background about what originally led you to delve into medical ethics, particularly from a Jewish perspective, given you've had this long career as a teacher and a clinician and an investigator at Baylor. How did you get started and decide that medical ethics would be one of the foci of your career?
Well, about 40 years ago, I was in a serious Jewish study group, and one of the speakers, Rabbi Yitz Greenberg, in discussing the Third Jewish Commonwealth, made a comment in passing that a doctor steeped in Judaism would practice medicine than one who was not. So afterwards, I asked him about it, and he basically said, do not do unto others as you don't want them to do unto you. The rest is commentary, go study. So I started studying Jewish medical ethics and realized what he had told me was absolutely correct. So that's really what got me started in that whole area. So I'm grateful to him to point that out to me.
So tell us a little bit about the circumstances regarding your course and how it was received in the past and what happened that led to this cancellation, really, of your whole approach to teaching the students.
Sure. About 25 years ago, I went on a trip called the March of the Living, which takes high school students to Poland and Israel. Standing on the ramp at Auschwitz, where Joseph Mengele was standing, I began wondering what did they need a MD and a PhD on the ramp to select patients to go left and right. So I began studying the issue and realized there was a lot to be learned about contemporary medicine by looking, eventually decided to offer a course describing how the Holocaust came about and the central and indispensable role of physicians in designing and implementing the Holocaust. And the course has been very successful. Not many students sign up for it. At the end of the course, they have to write an essay about any aspect of the course that they found stimulating. And most of them learn a great deal, and without my even asking them to apply it to contemporary situations, most of them would do that. Because the relevance of that, what happened in Germany back then, is clear to students who take this course. The course was held in abeyance during COVID. When the course came back after COVID, the student body seemed quite a bit different to me. And in this course's lectures, the fifth one was about why the Jews, talking about anti-Semitism and the history of anti-Semitism. But the main point of that particular lecture was countertransference. This is a phenomenon wherein, well, first I'll begin by saying what transference is, where it works like this. Let's say a patient has some issue. She may choose a doctor that could help her resolve that issue because of certain characteristics of that doctor. For example, a woman with daddy issues may go to a psychiatrist and choose an older man, and she can work out issues better with that sort of psychiatrist. Similarly, a patient may stimulate some emotional reaction in the doctor, and the doctor may let that emotional response interfere with their delivery of medical care to that patient. So in this day and age, where there's a lot of classifications of everybody by race, if you're the wrong race, the wrong gender, the wrong religion, the wrong whatever, political views, it may stimulate that reaction in the doctor. And this particular student body that I think, not just this year, but for many years now, they are very reluctant to make judgments about anybody, including themselves, and express that they have any bias, except against white people. And Jews are considered white people. So when I'm pressing on them to talk about their own biases, they're very reluctant to address that because they don't believe they have any biases, which is a little bit absurd. So one student apparently took offense, filed an anonymous grievance, and I went through the administrative process, during which time I learned that anonymous grievances are encouraged to protect students who are considered a vulnerable population. And I think it's pretty clear they've lost sight of the objective of medicine, which is to treat the real vulnerable people, which are the patients. So that was rather a startling discovery to me, that they treat the students as a vulnerable population, which really is absurd. These students are in their mid-20s. The idea that they can't speak to their professors about what's troubling them just seems absurd. So that's the story in brief.
You know, I recall when I interacted with students at Penn, where I taught and was an associate dean for curriculum. One day they were complaining about microaggressions in the lecture hall. Somebody made a comment, used an adjective that they found somehow offensive, and I pointed out to them that they really were first responders. They were going to work in emergency rooms. They were going to see the most horrible things that they can imagine, and if this bothered them, they probably ought to find something else to work in. And that was not very popular, as you've encountered, but that was before COVID, and I wasn't canceled at that point. Later on, perhaps, but not at that point.
I mean, that's clear. Patients are going to say whatever they're going to say. They may have many, many biases, but part of becoming a doctor is you look past that to the individual patient and help them as best you can. Because patients when they're sick, they're not necessarily at their best, and you have to be able to tolerate all sorts of indecencies that may come from patients and maintain your equanimity. But if you yourself feel you're vulnerable and you're being abused by a patient, how are you going to treat them?
Yeah, exactly.
It's interesting. I just have to say, as a personal comment, being way back when, I was the only woman on my surgical team, and I had a prisoner patient say, I can't even say the word that he called me, but he didn't want that touching him. And I thought, if I shriveled up and shrunk away, what would that make me? And it's just what you're saying. We're first responders. We're supposed to learn to be tough. And patients are going to do that. They're going to call you names. They're going to treat you poorly. particularly in these emergency room situations. Good for you for pointing that out.
I must say most patients are very considerate and kind of the physician, but there are many times when they're not because of circumstances. And if students can't even go up to their professor after class and discuss something that makes them uncomfortable, after all, this course I'm teaching is designed to make them uncomfortable. I'm showing them raw footage from concentration camps, really horrible things. It's designed to make them uncomfortable. Of all the things in the course that makes them uncomfortable, the use of the word Palestinian is the one that resulted in anonymous grievance. If you can't handle like going up to a professor and complaining about something you find absurd and perhaps learn from your professor, you're going to have a great deal of trouble in medicine. Plus, it will distance you from the patient. If you're constantly on guard for microaggressions, how much attention you can actually pay to the patient's needs if you're sensitized to microaggressions. So it's very problematic.
So let's take it into the current idiom that we've been dealing with. And so physicians who have expressed sympathy for Hamas and its attack on October 7th have been accused of violating the Hippocratic Oath, or at least have rendered suspect their ability to treat patients who are Jewish. Do you think this is a valid judgment? How do you see the countertransference entering into this activity?
Well, I think the people who are making comments like that obviously have not learned about countertransference or else have rejected it as a concept. I mean, to go publicly blasting a group of patients is totally disreputable. There was a physician who worked at Lenox Hill Hospital who made that judgment and spoke out saying the Israelis are getting a taste of their own medicine. And Jewish patients made it clear they're never going to Lenox Hill Hospital, so they fired that person. But she's not the only one. I mean, it's not compatible with medicine where you treat people as individuals rather than as groups. It's a bad thing when people are coming out saying bad things about Jews like that as physicians. They need to maintain their equanimity and be very careful about what they say.
Well, doctor, do you think because of this DEI training, it's made people start, as they say, othering people? Whereas before, it seems like, as you pointed out, patients are just individuals. You're looking at the condition and what they've come in to see you with. And suddenly we're being told to look at people as part of racial groups. Have you seen that change over the years that you've been teaching?
Absolutely. I mean, and it's institutional. It's in medical organizations, medical journals. When this case came up to the Supreme Court about the ruling against affirmative action, the American Medical Association at the time urged medical schools and undergraduate admission committees to proactively implement policies and procedures that operationalize race-conscious admissions. That's what the AMA is saying, and they're not alone. Many professional organizations and journals are doing the same thing. They're encouraging physicians in training to look at patients with a race consciousness that I think is destructive to the doctor-patient relationship. Yeah, I think it's a problem.
You know, one of the questions that's arisen has been the basis for the poor health outcomes of the black community. And one of the arguments that, frankly, our organization, Do No Harm, has been fighting against is the notion that this is due to the biases that you mentioned earlier. And I sort of wonder your thoughts about this idea that these biases are so strong that they can overcome the practice of good medicine, or in fact, which is our particular view, that people have free will. They may have biases, but they overcome them with based on their training and based on their understanding of ethics and how they need to comport themselves despite their biases. What do you think about that?
Well, look, everybody has a certain amount of prejudices against different groups. For example, from birth, you're right away prejudiced against anyone who's not your mother. But as you mature and grow up, and you start acknowledging that's part of the human condition, you have to work to overcome them. The idea that systemic racism is what's causing the disparities in outcomes for different populations, there may be some element of racism, but I think it's a very minor part of it. But to say that out loud can get you in trouble. In fact, there was a deputy editor of JAMA, Ed Livingston, who was asked to do a podcast on systemic racism. He invited an expert in. And in the middle of the podcast, he said, if I understand what you're saying, because I'm a white person, I'm a racist. And the guy says, yes. So for that, he was either forced to resign or fired. It's not clear. So the very idea of confronting the notion of systemic racism gets you in trouble. And of course, ideas like that need to be confronted, because if it's really contributing to healthcare disparities, you want to do something about it. But if it's not, you want to go after those things which are contributing to healthcare disparities. So suppressing discussion is not a good thing in general. It's hard to advance the treatment of patients if you can't discuss what's really going on right before your eyes.
Doctor, there's something that struck me that you said in the article you wrote in the National Review about what happened to you. And you said when the student had reported this anonymous grievance, the director said she had no choice but to cancel the class. And it reminded me of a book I had read years ago called The Nazi Doctors by Robert Lifton. And it had really made a profound impression on me of the idea of going along to get along. And when I read that you said the director said she had no choice, I thought, well, we always have a choice. What was it that made her have no choice and have to say, now you're canceled?
Well, I think part of it is just many of the faculty, even though they may disagree with the policy, the other person who gives a lecture with me, for example, is a highly regarded scientist. He was nominated for a Nobel Prize 2 years ago. They canceled the lecture. I don't know whether it's because of me or him or both of us. I don't know, but I think the subject matter may have been dangerous for them to talk about. Yeah, I think a lot of the faculty go along even if they don't agree with it. I saw one of the comments in the National Review article is that, yeah, they're behaving like people are just following orders. And I think in a certain sense they are. This is the party line, the DEI party line, and they're going to stick with it. Nobody's standing up and saying the emperor has no clothes. This is absurd. Anybody's practiced medicine for a while knows you can't possibly deliver good care when you view the patient as part of a certain group. It's just not possible. You're bringing your bias right into the middle of the doctor-patient relationship.
Well, it's stunning to me that this sort of thing is acceptable. And all I can do is think over my entire career where I would say the bias that I had would be against drug dealers or something like that. When a drug dealer would come in trauma and you're just thinking, oh, I have to take care of him. But to look at people by their race, we went so many years trying to get rid of segregation. And this whole concept of resegregating in general, and worse yet, resegregating in medicine, it's sad. Doctor, how do we turn it around?
Well, I think it will require some legislation for sure. This legislation that Do No Harm is pursuing. And I think education in the classroom to professional organizations and to medical journals is important. I mean, after all, the fundamental fault of the Nazi doctors, who were the best in the world at the time, is they decided to classify patients by race, which is exactly what's going on now. So it's very dangerous. One of the reasons I like teaching that material is it can shed a lot of light without much heat, because you're not talking about contemporary times, you're talking about distant times. People would like to think that the Nazis were some people who came here from outer space, stayed 12 years, did a lot of damage, and left. But that's just simply not the case. So like education like that is important to let the young trainees in particular know what's going on. In fact, I only teach freshmen because I want to get to them before the rest of the medical faculty gets to them. And it usually helps a lot. But now the DEI is so bad. The educational system itself is resistant to learning new things, as it were. And we just got to keep fighting against it. I don't see any way around it. And at multiple venues, the courtroom, the classroom, the professional organization, the journals, just have to keep fighting against it.
Well, Dr. Rubenfeld, that was a very interesting discussion, and we really appreciate the the efforts that you've made. And I think the lesson from the Nazis to current times that you've just outlined is really a critical one. And hopefully we'll start to see the world turning around a bit. I think there are some green shoots, if you will, out there. Some of it is driven by legislation, but some of it is driven by, I think, the realization that DEI has really contributed greatly to the antisemitism that we now see throughout society and in medical education as well. So we thank you very much for your efforts and really great speaking with you.
And if I just had one final word, I keep thinking of a paper by Francis Peabody that was written almost 100 years ago about the secret to caring for a patient. He said the secret to caring for a patient is to care for the patient, not to care for a specific group of patients.
I'm sorry. One more thing is that you've written a number of books about this topic and these issues, and I just wonder if you would just mention those for the audience who may be interested in following up on some of these ideas that you've expressed.
Well, a general book is called Medicine at Holocaust, which gives a broad overview of what happened back. And there's another one I think would be very helpful as an example of how you apply ethics to medicine, called Physician-Assisted Suicide and Euthanasia before, during, and after the Holocaust. And it takes one specific issue, end-of-life care, with a focus on physician-assisted suicide and euthanasia, and looks at specifically what the Nazis did and what's going on today in Europe and Canada and even the United States. So I think those two books together will give you a very good idea of why studying medicine and the Holocaust can be very enlightening for what's going on today.
Well, thank you so much for that, and I really hope people do check out those books. I certainly know I will. And I'd just like to thank you, Doctor, for all your courage and continuing to speak out, because this is what we need. And I'd like to thank everybody for listening, and thank you for supporting our efforts to protect patients, physicians, and healthcare itself from this divisive ideology. So please visit us at donoharmmedicine.org, and thanks again for listening.